In the heart of Accra, nestled in the vibrant neighborhood of East Legon and New Beacon, a 360 multimedia firm has emerged. Introducing ZED Multimedia. With a steadfast focus on lifestyle, leisure and business, we set out to bring high-value oriented programs that captivate the taste and desires of our audience. From the captivating airwaves of ZED 101.9 FM to the dynamic visuals of ZED TV and the innovative realms of ZED Digital and the incubation of advanced technological knowledge at ZED Tech, every facet of modern media is meticulously curated to engage and inspire. Also, let's not forget the New Finder newspaper, now under the ZED Multimedia umbrella, delivering insightful journalism with a business focus. Join us on the journey where innovation meets inspiration, where lifestyle meets leisure, and where business thrives. Change is here. ZED Multimedia, your lifestyle, leisure and business platform.
Dream home. No interest for 2 years. Are you ready to step into your dream home? With Lakeside Estate's exclusive offer, you can own your own home in just 2 years with no interest repayment. This offers you affordable payments, flexible home purchase plan, quality homes, and lifestyle choice. Choose from a variety of beautiful homes in any of Lakeside Hills clusters. Your future awaits you. Imagine living in a home you love with the freedom to invest in your dreams without the burden of interest. As your CIMG Real Estate Company of the Year for the 4th time, we offer you hassle-free home acquisition. Call us today on 020-477-5040 or 020-141-8622. Don't miss out on this incredible opportunity. Call us now to learn more and schedule a tour for our available homes. T&C Supply. Make your dream a reality. Lakeside Estate. Quality homes for all.
Hello, good afternoon, and welcome to the ZED Wellness Link. My name is Dr. Padiaite. Today we are starting a few minutes late. Please forgive us, but it's for good reason, for very good reason. But we shall compensate by ensuring that you have a very, very lovely show. Today we are talking about breast cancer. October happens to be Breast Cancer Awareness Month, and it's our hope that we shall be as educated as possible in this area to ensure that as many people as possible can either, catch it early, know how to manage it, get rid of it as quickly as possible, and if possible, even prevent it from actually occurring. We have 2 guests with us today. Our guest in studio right now is Lady Ajo.
Yes, please.
She has some long, nice name, but she's a mindset coach, licensed counselor, and development consultant.
Yes.
And we shall start with her and our discussion about breast cancer. Mm-hmm. Breast cancer is one of the most common cancers that women encounter. Also affects men, not only women.
Yes.
In your experience, when somebody is told they have breast cancer, how do they respond? How do they react? How do they feel? How do they behave?
Well, first of all, I'm sure that hearing that you have breast cancer is not something that anybody wants to hear at any point in time at all. So such news is first received in shock. So the first emotion is denial. Oh, it's not true.
It's not true.
It's not true.
God forbid.
Yes, God forbid. Yes, it's not, it can't be me. You start to process this by thinking about what could have brought me here? Mm-hmm. How did I get here? Mm-hmm. Where do I go from here? That uncertainty sparks a lot of emotions in anybody when you hear such a news. And unfortunately for us in Ghana, let me just say Ghana, how we break the news is a bit...
Some way.
We just drop it on the person without any mindset prep for the person to know that, okay, there's something that is about to change in your
Oh no, we prepare the patient too. We tell them that go and bring somebody from your family.
It's not a family member who's going to be dealing with.
And that family member will come and sit there. They say, no, I can't tell you alone. You go and come. So you go for 2 weeks with anxiety to go and bring the family member on TV. We are wondering what did they want to say. They come and sit there. Then they do it. They drop it.
But do you know that sometimes you having somebody else there to hear your bad news is not the best approach.
Yes.
Because sometimes people want to process it, accept it before they tell others.
Yes.
And some don't even want others to know, because when others know you are sick, the way they treat you can even make you more sick.
Yes.
So,
But somehow people seem to think that somebody must be there when you get bad news, so that in case you start raining on the floor, they would manage you.
it's how you prepare the person's mind for the bad news.
So we don't need that person.
You need the support of people, but the first person who must accept it is not the family member,
Okay,
but the patient itself.
Yeah. Okay, so we don't need family member.
I didn't say you don't need family member. You need the support of
We
family.
need the support of family member,
but the
patient must get the information first
and accept it.
before we can ask
And
permission
then
to
whether you break it to them or they want their
them
family members to know.
Okay, so that is your problem with how we break the news. So we don't break the news well.
Yes.
Okay, and then
The emotions that comes with it, it takes time to process. Such news cannot be rushed, and you cannot just say that, okay, today you know you have breast cancer, so this is no. Allow the person time to adjust to their new reality. Most importantly, this is the time that I would advise that you bring in a counselor to speak to the person. And most often in this setting, what they need most is grief counseling. When people hear grief counseling, they usually think that it has to be about you losing a loved one or something.
Yeah.
But whatever changes what your reality is and introduce a new reality to you brings about grief. Okay, so losing a part of your body that you are attached to can severely change how you see yourself.
Okay.
And how you even accept yourself and how you live life onwards from there is very important.
Okay, so I got that. How do they typically respond?
Denial.
They don't believe it.
They don't believe it.
And then what?
The pain, the shock.
The shock.
Yes.
Okay.
And then it's you see, emotions cannot be prescribed to one person. It's not a tailored thing that this is how everybody should feel.
Okay.
How each person might process their emotion is very, very different. And so you might tell me something that will shock me, I will laugh. Another person would want to be isolated for a while to process their thoughts. Another person might cry. Another person might be aggressive. So each person and how they process their emotions. And so I can't say that, okay, one size fits all. This is how everybody will react. No. It differs from person to person.
Because my concern is how they choose to respond oftentimes, and how we can get them, after they've gotten the news, to accept treatment. Because there are so many instances where the client is told, this is what your problem is, this is what we think needs to be done, these are the interventions that we are suggesting should be put in place. And the response they give you is, okay, like you said, denial. But soon afterwards, the next thing you know, you tell them to go and come back, and they do not come back.
Yeah.
For a long time. And they go, round to all kinds of places looking for solutions before they eventually come. Is it because we don't give them enough information for them to realize the gravity? Or is it because we don't educate them enough to know the plan there is for them for what we can give? Or is it that they are so beside themselves with grief that everything you said about what your intentions for them, they don't listen, and then they try and find alternative solutions? Because that is one of the problems that we face.
Yeah.
The moment you are told that this is your problem, the way they respond or the way they react is not always the best for their care. And I'll give you an example. So a young woman was diagnosed with the fact that she had got breast cancer. And the intervention was they needed to do surgery for her breast and chemo and that kind of stuff. Her reaction was she hasn't given birth. And they're like, oh, but, this can kill you. And after it has been sorted out, yes, we can talk about the childbearing instance. But she was like, no, she hasn't given birth. And then she disappeared then appeared with a fungating mass in her breast. Eventually, it killed her. She didn't have the baby, though, but eventually it killed her. So, and we would like clients to get the best possible, care. So where is the gap in your experience? Where is the gap in the way we are having that conversation?
Well, when it comes to individuals and the image they have carved for themselves, it is very difficult to detach them from it. So, like the young lady you spoke of, she saw that without that breast, it would be some sort of deformity, or it would make her inadequate to be a mother. And so her priority was what influenced her choice at that time, that she wanted to be a mother, to breastfeed that child without feeling like, oh, there's something missing. Okay, so she chose that. Now, even though you told her everything that you told her, she still chose her priority, which is being a mother. She didn't think much about the child's health afterwards. And that's a conversation that could have triggered her to consider that, okay, you want to have a child, we understand you. But if you have the child and you do not take care of this early enough, you would lose your life. Then what happens to the child? Then you give the person the opportunity to start thinking, processing that thought that I'm going to have a kid I'm going to leave behind anytime soon if I don't take care of this. But I could also have the surgery now and have one breast left. I'll take care of my daughter and still have life with my daughter. And then it will not be so bad. But once she's seen it from one angle, that is all that she's thinking about. And so there will be this sense of adrenaline that will keep her going. She might not even be paying attention to the pain, but focus on her priority. The mind has an amazing ability to numb pain when you are focused and zoomed in on something. But when you start to process things differently and start to see it from a different perspective, then you begin to open yourself up to, okay, this is possible. Then the options become available to you. But until that is done, the mindset is zoomed on one thing. That's the only thing they see.
Wow. Okay. That is work that we have to do.
Yes.
In that particular...
in the awareness bit of it.
Area. And
yes.
We'll come back to that. We haven't finished. Because it's something that really bothers me. Ladies and gentlemen, it's time for us to go on our first break. Our first song will be This Far by Grace. Afro. Is that a different version? By Pastor Edwin Datson. He's a general surgeon and who has quite a bit of experience with breast cancer work. So, Dasaki, before when we started, we're talking on the psychological side of things and the areas where we as doctors don't do well in the way we communicate our information and how we can do better. Why is breast cancer a significant public health problem?
Oh, thank you so much for this time. Breast cancer has been an issue for some time now. I mean, it affects both men and women. Unfortunately, we forget about the men.
You've not been telling us everywhere you say palpate your breast. Have they told you to palpate your breast? Nobody has told me to palpate my breast. Me to have to do the palpation song.
Exactly. So it's unfortunate, but like everyone has a breast.
Yes.
Both men and female.
So that your pink tin, you have to do the blue one too.
Yeah. we'll get one for you. So, I mean, cancer is more like a condition that when it gets to a certain stage, it cannot be cured. In the early stages, there's hope for cure. So
it can be cured.
It can be cured if it comes early.
If you come early.
Yes.
Okay.
Yes. So that is why now we really want to emphasize on people getting screened as early as possible so that we have as many people surviving breast cancer. Yes. So that's the main thing. We really want as many people who eventually become diagnosed with breast cancer. It said in a lifetime, 1 in every 12 women would probably be diagnosed of breast cancer if you live long enough.
What secondary school did you go to?
Every girls.
Every girls. How many were in your class?
We're like 30.
30?
Yeah. So at least about 2 of us.
2 or 3 of you
2
in
or
that
3
class?
in that class will end up getting
your own classmates?
Yes.
Okay. That brings it rather close.
Yeah, really
the fact
close.
That it is closer.
Yeah,
so assuming you're in a family
think.
and there are 12 and there are 12 females in your family.
Exactly. If you live long enough.
Yeah.
Yes. So I
understand it's the most common cancer.
Yes, the most commonest amongst women. Yeah. And
I don't know, is it more common than prostate cancer?
It's generally more common than prostate cancer.
So it means it's the most common cancer, period.
Well, in Ghana, yes.
And it's preventable.
It's preventable.
So nobody needs to die from breast cancer.
Absolutely not. But unfortunate thing is we get a lot of late diagnosis. And I mean, with that, there's really not much you can do. You can just do the palliative management and do the supportive treatment. Yeah.
Let's try and get a message across.
Yeah.
What are you supposed to do to ensure you can pick breast cancer at the earliest possible stage? Okay,
so
you, the individual.
As an individual, so it's recommended, especially for the women, that every 5 days after your menstruation, after your menstruation starts or ends? 5 days after it ends. After it ends. So we are looking at something around day 10, day 9, day 10. Exactly. Okay, of the cycle. You do what we call a self-breast examination. So that you stand in front of a mirror, look at your nipple, divide it into 4 equal sizes, and just with the your palm being flat, just try to, palpate, as in touch the breast. Press the breast against the chest wall, exactly. Okay. And, you may not find anything, but what it does every month, it helps you to get what we call a memory of how your breast feels. Normally feels like. So that at any point in time, when there's the least change, you'll be able to detect it. And at a certain age, by age 40, is recommended that at least every woman should get a mammogram done to be able to diagnose it. How often? Every year after age 40. Yeah. It's radiation now. Yeah, it's radiation, but at least. And they squeeze the breast. It's painful. Yes, it's painful. So we'll not do it. Give us something else to do. The benefits of detecting what palpation might not be able to pick up very small. But you can do ultrasound too. Yeah, you can do ultrasound, but ultrasound is better when in very dense breasts in the younger ones. So if someone comes in and we suspect that there's a high risk of the person getting a cancer, she has maybe a family member, a sister, a mother who has ever had a breast cancer, and she feels that the breast is different or she's having a pain in the breast, then we recommend that you do the ultrasound. Okay, so let's not jump. Let's go back. We are supposed to palpate our breasts
around the 5th day after the menses ends. Every month.
Every month.
So we stand in front. I'm repeating what I got from. We stand in front of the mirror. And we look at our nipple. And make sure our nipple is still pointing the way it was pointing last month. Exactly. If the nipple has changed direction, left, right, up, down. I look long. Any of those things, we have a problem.
Exactly.
Okay, so that is the nipple position. Then we divide the breast into four. And then we press the breast against the chest wall. And we are looking for any lump or mass that we may find. We are going all the way around.
Exactly.
Yes?
Yes.
And if there is no mass, we are fine for now. And we repeat it next month.
Repeat it every month.
In the event that you find a mass that was not there last month, even if you are not sure, what should you do?
So you go immediately to the nearest hospital, see a doctor who also clinically examine you and take a history from you, then also recommend any investigation that is necessary. So usually we'll do either the ultrasound or the mammogram or both to confirm what exactly it is. Yes. But we have to know that it's not all breast lumps that are cancerous. Yes. We have a lot of young people who come in with lumps in their breast, some as young as 11 years old, 12 years old, but it doesn't mean it's cancer. So if you find a breast lump anywhere, just come to the hospital. Let the doctor also examine you and also give his expert opinion.
So if they confirm that there's a lump, then typically what would we ask you to do?
So typically we'll let you do, so in the diagnosis of breast cancer, we call something triple assessment. So examination, like taking your history and examining the patient is one arm of it. Then we'll do an imaging modality. So we'll let you do either mammogram or ultrasound or both. Then if a lump is found, then we do what we call a biopsy. So then, so the biopsy will depend on the nature of the lump, whether it has what we call a malignant, cancerous features, or it has a non-cancerous feature. So we could just take part of the mass and take it to the lab. If it's small enough, or we don't have any suspicion of it being a cancerous mass, then we can take everything and send it to the lab just to confirm it's by the pathologist to be able to tell us whether it's this type of cancer or not.
All right. So at that stage, we'll know what we are dealing with.
Yes, at that stage, the moment the pathologist gives the diagnosis, then we know what it exactly is.
Then we move to?
Then we'll move to treatment options. Yes. So, but before we get there, we have to, if it's cancerous, then we'll have to what we call stage the disease. So we need to know the degree of spread, whether the cancer is just located just where it's located or it has gone to other parts of your body. So we'll have to do some investigation, blood tests, CT scans of various parts of your body just to determine that. And we then will stage it, stage 1 to 4. Stage 1 is the very early disease, and 2 to 3, 4 are very late disease. So depending on the stage that you fall into, then would discuss your treatment option. So stage 1 and 2, you have the probability of cure. So would discuss the options, one of which surgery plays a key role in it. And unfortunately, it's at that stage that a lot of the women get emotionally disturbed because as they assume we are just going to cut off the breast. So there are various ways. So either it depends on the size of the mass, definitely, and the stage of the condition. So if it's very early, small mass, you can do what we call breast conservative surgery.
We can save the breast.
We can save the breast.
We can remove the cancer.
Yes,
and
we just
save
take
the breast.
a part of the breast.
Okay.
Which is one option. But it will depend. Your doctor may not give you that option if you don't fall into that category of patients.
But that's the option we like.
Yeah, but unfortunately, in some patients, when you do breast conserving surgery for them, they don't benefit from it. They rather get worse.
No, you have to make sure that we catch it early so that we can do breast
conservation. Yeah,
conservation.
definitely. So if you catch it early, why not? I mean, If you come,
so your reward for catching it early is that you have breast conservative surgery.
Exactly.
And we don't cut off the breast.
Exactly.
You only take a small portion where the problem is.
Yes, where the portion is.
And then the rest of the breast is fine.
And the rest of the breast, we can't say it's fine because we can't see it microscopically. But afterwards, you may need to continue treatment, either radiotherapy or chemotherapy, to just try to reduce your risk of recurrence. It's coming back.
But the breast can be saved.
Exactly. The breast can be saved. Yeah.
So that's option A. They should always choose option A.
Yeah, but it's not.
Some people don't choose option A. They like
most,
option B and C.
Most of the patients who come don't fall into that category because they come very late. Like if you wait till you have like a wound on your breast, you know, before the cancer progresses, you get a wound on your breast that's gone through your skin. It's that means it's probably spread.
Okay, so you let's not. We're talking about the surgery.
Yeah,
let's see. So, in the event that your breast lesion is too big to do the breast conservative surgery, then what's the next option?
So you will need what we call a total mastectomy.
Total mastectomy.
Yes.
That means total removal.
Total removal of the breast.
Of the breast tissue.
Of the breast tissue. With the fascia, underlying fascia.
And you after that you do what?
So after that, there's the option of reconstructing.
It's not option, it's compulsory. You see, it is because
it is,
no,
but I mean,
let the person say they don't have the money. But if you don't offer it automatically, then all they think about is we'll remove the breast.
Remove it, but you know, some patient might not want it.
No. It is we are going to remove the breast tissue and we will reconstruct it for you. And the bill is X. And I can't pay that one. Just do the first part.
Yes.
We should.
So usually we cancel them about. Oh, you need a mastectomy.
And we shall reconstruct for you afterwards. I have to add that part.
Because, you know,
that is what gives her problems.
Yeah. The issue is you can't really offer the reconstructive straight away because you have to make sure that the tissue margins are clear.
You will do that. So we'll do frozen section.
Unfortunately, I don't know anywhere in Ghana here where we do frozen sections. And so like it's really difficult, you know.
No, but we can offer the reconstruction day one.
Even after the mastectomy is done, it can be done later. It doesn't have to be in the same setting.
No, I don't think it has to be at the same setting. But we can offer it to the client from day one. For the client to know that is their plan.
Exactly.
If we tell you and your family members have destroyed the thing, we can't go further. It's not. I think them not knowing that the breast can be reconstructed is what also makes them feel like then I'm going to think about it.
Yes.
Because I can't afford to lose my breast, but the husband will look at me some way.
Exactly. It's unfortunate.
You understand?
Yeah.
So please, breast surgeons, endeavor from day one give them that option.
Yes.
And tell them how much it is. And let them say, oh no, we don't want that. We can't afford it.
Mostly the plastic surgeons who do that. So we would let them talk to them.
No, you are talking to them about it from day one for them to know that this option exists.
Exactly.
Please, I beg you.
We'll do that.
It's really important because I think it contributes to them not willing to start.
Not coming,
because they think,
there's no other way.
You understand? There's no other way. My friends will be looking at me some way.
Yeah.
You understand? Okay. So if you can't do conservative surgery, then you have to do total mastectomy.
If it's an early disease.
It's an early disease. If it's a later disease, then what?
So if it's a later disease, we usually start with the chemo. And
why?
So the aim of the chemo is to try and reduce the mass, the swelling.
For future surgery? Or just reduce?
Yes, so for some people for future surgery. For others is for other reasons, like people coming with very huge fungating mass, you know, very foul smelling, ulcerated. You want them to reduce the ulceration, try to help it to heal up, or at least reduce the size a little, in hope that you could do what we call a toilet mastectomy. Toilet mastectomy means you are not really aiming for cure. It's just to keep the place clean and, how should I say it? Clean. Let me just keep it clean for the patient. Yes.
So that the patient does not have to deal with the huge smelling rotten
and
mass.
all. Exactly.
Okay.
So with those who have like large masses, the skin is intact. You start the chemo. For some of the patient, they respond very well. The mass shrinks to an appreciable size that can help us to do the mastectomy for them. For others, if they don't respond, they will have to go to a second line of chemotherapy and try to, fight it, yes. The other things, therapy that can be done, immunotherapy, for those who have the immune receptors. So, yes, those are the options. And radiotherapy, I forgot about that.
So radiotherapy is for which people?
So radiotherapy is for first of all, it's for those who have had total mastectomy, early disease. We want to radiate their chest just to make sure there's no other residual cancers. It's also to help to control any bleeding. There are some of them who are very bad ulcers that is always bleeding. So they always come in very anemic. We can do radiotherapy to reduce that, yes.
The treatment options. So who are those who survive? What stage?
So it's a very dicey question because you can't really tell who would survive, but
which stage has a greater likelihood of survival?
The greatest likelihood is stage 1. They have a very high 5-year survival rate. Okay. So by 5 years, at least 50% or more will be alive. Yes, will be alive.
So our focus should be on getting the disease at stage 1.
At stage 1. That should be our focus.
So everything we do should be, how can we get the majority of our disease at stage 1?
It's aggressive, like screening exercises. Unfortunately, we do this sort of screening and discount for breast cancer screening only in October. So we find that in maybe June, July next year, you find patients who come in, they've had the mass for like 6 months and they are not doing anything about it. I don't know whether they are waiting for screening time or they don't know about it.
I work in a hospital.
Yeah.
What can we do in my hospital to help pick up early stage disease?
So we can easily set up screening booths because we can get screening with breast cancers. We can do clinical breast examination, which really wouldn't take much from us.
So any woman who works
for any reason and wants to get her breast
we should offer her
we can offer
breast
that,
examination.
yes. Or any man, of course, because the men's breast cancers are also increasing.
Their risk is low, so let's worry about the people who have the biggest.
Their risk is low, but when they
get it,
I've actually seen about 2 or 3 in the past 2 months. Men. But it's not confirmed yet. They just have a lump in the breast. And usually when a man comes with a lump in their breast, it's considered to be cancerous until proven otherwise. Yes. Because
Mr. Kant, have you examined
and the fortunate thing is for the men, when they come and you manage them early, it's like it's complete cure. Like you're able to remove the whole.
Yes, because men come when the lump is small.
Yeah. And it's easier to detect in the men because they have less.
We look for it. When you get up now, hey, what? Hey, am I drinking too much? Something else. Let me go and deal with it. Maybe the wife will tell you that, hey,
yes. But the men too are also in denial, though. When you tell them.
For the men, they don't know that a man can have breast cancer.
Yeah, exactly.
The education hasn't gone enough.
No. We haven't. So our biggest problem is get them at stage 1.
Exactly, stage 1.
And we can do that by frequent breast examinations.
Yes.
So if we say a woman must do a breast examination every month herself, let's decide on a day, let's say day 10 of your cycle. Yeah. So once it's day 10 of your cycle, do the breast examination.
Exactly.
Or whenever your menses ends, just do it so that we are.
But you have to add that, like for those with a high risk, like those with a family history, they have to be more aggressive.
So if somebody has a family history of breast cancer, they need to do what?
So such patients, they have to try to do what we call the genetic testing for the BRCA1, BRCA2 gene.
The Angeli Jolie test.
Exactly. If you're able to know that they have that, then such patients recommended they do like mammogram almost every year.
Okay.
Yes. So it's one of the things, because there are some of the lumps you don't palpate it at all. Some patients are able to pick up their, breast cancers from my MRI scans. They went to do MRI scan for something else and it was incidentally found. And it was so small that even the biopsy had to be done under MRI scan guidance. So it's something we have to look for.
So if you are a normal person who has no risk, do your palpation every month.
Every month.
And the moment
when you get to 40, go for mammogram.
Or ultrasound. I'm dodging radiation.
Yeah.
Do at least one.
Do at least one.
The other one is if you have a family history.
Yes.
What do you mean by family history?
So your mom has been diagnosed of breast cancer or ovarian cancer, or anyone in your family has been diagnosed of colon cancer.
Colon?
Yes.
Hey, that one too?
Yes.
The prostate is not inside.
The prostate is not part.
If your prostate is inside, though, that's
the gene that is responsible for that usually causes colon cancers.
Colon.
Yes.
Okay.
Ovarian, breast, colon.
So if anybody in your family, male or female, has ovarian cancer, has had ovarian cancer, colon cancer, or breast cancer, get tested for the BRCA1, BRCA2 gene. Where do you do that test?
For now, I don't know. Or any genetic testing laboratory.
That's a big thing you're asking for. Okay, we'll find out where it can be done. So that
just find out.
If you do want it to do it, you can actually get it done. But once you get that test done and you have the gene, then I guess you should see a breast specialist.
Exactly.
At that point, see a breast specialist so they can discuss
the options
that are available to you. I deal with it. Okay. These are the treatment options that are available to the patients. How do the patients usually respond when you offer them those treatment options?
So majority of the patients actually respond.
No, how do they respond to you?
Not
to treatment.
Not to treatment.
When you tell them that this is the plan.
So, everyone is...
She was talking about denial and things, but...
I was going to actually mention that. I would say most of them, most patients would actually be in denial. Some will refuse that, no, it cannot be. Even when you have, diagnosed it pathologically, they'll say, no way, this can't be cancer. So some will think, it's just a boil, it will go if you use antibiotics. Others are able to accept it, not in the first instance, but it's a mental thing, she's been talking about it. No one wants. It's even for us, the doctors. Sometimes it's really difficult breaking it to the patients because
why?
Some come in very young, and you have to break that news to the person. It's not an easy thing to tell someone a bad news that he or she has cancer, and probably it's a late stage, and her chances of survival is very low.
So do you tell them they're going to die?
So I
don't tell them the truth.
Well, I've had an instance where a patient asked me, doctor, am I going to die? And I told her, well, I can't say for certain that you will die. But for cancers, whenever you get cancers, your lifespan tends to reduce. It reduces the time. If, let's say, you were going to die in 10, 20 years, it probably would reduce it to about 10. But I cannot tell you for sure. But I don't know what she heard, and she felt that I said she would definitely die. Because sometimes what you tell the patients is not really what they hear. Exactly.
So when she heard you said she was going to die, she said you're a bad doctor.
It wasn't easy.
You're a bad doctor. She said she's going to die.
That probably almost beat me that I said she's going to die.
So the moment you said that, I started thinking of something. So let me be a bit controversial. We are all going to die.
Yeah, we are all going
If Christ
to
does
die.
not come before the time comes, we will all die.
Yeah, we are all definitely.
So telling somebody that you are going to die, you haven't said anything.
Yeah, no, but you know, it's different. Like, you know, where we are, as we live, we have the hope of life. Like,
But everybody is going to die at some point in time.
You know, knowing that.
So why is she upset with you that you told her that?
Earlier than expected. Yeah.
Okay. So you told her that and then nearly beat you.
Oh, it was another. So.
One of the things I find fascinating is you meet a client who has gone through these things, and then you ask them certain questions, and so what did they tell you?
Yeah.
And the clients, you are saying this is end-stage disease,
yes,
and you're asking them what did they tell you,
yeah.
and they still give you some run around,
Exactly.
and they never tell that. You mean that? So did they tell you that you are going to recover? No. Did they tell you are going to die? No. What did they tell you? So I'm always wondering, is it the information that is not being given?
Yeah.
Or is the client that is not hearing despite everything that they were told? Which one is it?
I think it's probably both. I think it's also probably because of how we cancelled them. You know, sometimes you may have cancelled them in an environment where there wasn't enough time for you to actually help the patient process what you have told them.
Lady Ajo, how can we counsel these people better?
Yeah.
It's as if you're not doing well in that aspect.
Yeah.
They say if you are communicating and the person doesn't, it is your responsibility to make sure that you have said it in a language in a manner the person will understand.
Exactly.
And if this is what is happening, it's as if we are not communicating, we the professionals are not communicating well enough. Is that the case?
Yes.
Yes. Hey. The slap has been given to us.
Yeah, I actually agree with her because, you know, I'll let you talk for a minute because I feel there should be really like a formal way of counseling, training doctors and people who are often...
So there should be a standardized way of how we should break that news.
Break that news.
Breaking that news.
That news, yes.
Okay.
I think
Please,
ideally every
as the
hospital...
experts, tell us.
Well, I think ideally every hospital should have a counselor on board.
Yeah.
And the purpose of the counselor is supposed to... You see, counseling is not just about telling the person that, oh, this is what, but sometimes you can even profile the person at the instant to tell that this person, this is not the right time to even tell the person this thing. Because let the person relax, sit down, then be having a conversation, building up to the idea that this is where you are going to. So by the time you get there, the person has already started thinking about it in a certain way to accept it. But if you just go, okay, please, you have cancer. What do you want to do with that information? At that point in time, how do you expect the person to process it? The person is going to be, one, in shock. Two, like you said, they will say it can't be cancer. It can't be cancer because the person's first thought is, how did I get here? Why me? Did I do something? So there are questions that the person is asking themselves to figure out how they got here in the first place. Now, put that aside. The person is thinking, I'm going to die, because they haven't seen a lot of survival cases of cancer. We talk about cancer. We show the bad parts of cancer. Have we given people hope that there is something called cure?
That's a very good point.
We don't give hope enough. That, okay, like you said, if you can afford it, you can do... People are doing surgery for no good reason. So if this one, you can go and even get the size done bigger to make you look finer. You can give people...
We'll even work on the good one too, so that both of them will now Bobby
So you have to give people something to hold on to. It's just like you are drowning. And somebody tells you that, throw your hands this way, you survive. But you don't know how. But if I throw you a lifeline, I've given you hope. Let's learn to give hope in the way we communicate the illness to people. It's not just about, okay, you have cancer, you're going to die. I can tell you that studies have showed that survival cases are equally based on the mindset of the patient. The fight to survive any illness is not just about the physical bit of it, that the medication is working, it's mental. If you want to survive, you will survive. But if you die before the illness even kills you, you are long gone. And so we must communicate right, and we must give hope.
On that powerful note, we shall take a quick break, and the song for this break is called Higher, featuring Akese Brimpong and King's Kid. by Joe Metal. Today we are talking about breast cancer. Today, as you can see, this is an extended version. We are going beyond 4 p.m. and that's because there's still so much to talk about. And I've got great guests who are, giving us lovely information and how we should manage it. Lady Ajo is our great advocate for mental health and the way we should speak to our clients. She's been blasting us. We've not been doing very well in that aspect. Lady Ajo, we have repented. From now on,
I pray so.
We'll be on our best behavior.
Amen.
Dr. Dorcas Saki. Saki, yes, is our surgeon. Dr. Saki, I've been collecting some of your blasting for you. Please, I'll hand it over to you so that you. Is a surgeon who has been discussing the subject with us. Dr. Saki, sometimes patients are reluctant to take care because they have been told all kinds of stories about side effects. Yeah. And so I want to talk about two things. Side effects, and after that we'll talk about myths. Okay. So first of all, what are the side effects of the treatments that we know can happen? And so the client can prepare for that. Oh, in the event that this happens, they told me about this, they told me about that.
Okay. So one of the commonest that the patients with cancer who are breast cancer who are undergoing chemo especially undergo is hair loss. And
hair loss.
Like you lose all your hair, even on your skin, your eyebrow.
For those who are doing chemo.
For those doing chemo.
So they lose their hair on their head?
Yes.
They lose their eyebrow?
The eyebrow.
And so we go. They wear wig.
They can wear wig.
But a man can't wear wig. Women, they can wear wig. Oh, if you lose your hair, we can wear wig.
Yeah, but it's also part of us, like the image of women.
Okay. So if you take chemo, you may lose your hair.
You may lose your hair. Okay. Some also will develop very dry skin on their hands. Yes.
Does the skin get dark on the hands?
It gets darker. Very dry, dark skin.
Dry, dark skin.
Yes. Okay. Some also, depending on the chemo you are taking, your urine color might change.
To what color?
To like orange.
Orange.
Yes. Yes. So those are the main ones. Some will develop like itchiness. Others to, which is a very common side effect for most chemo medications, they become anemic. So you have to it reduces like your blood level, hemoglobin level. It could be from the cancer, but sometimes to the chemo medications too can cause that. So you tend to be very tired all the time. You don't have the usual strength you usually have. Some also vomit a lot. Okay. Especially immediately after the day after that they take the medication. If the vomiting become too excessive, there are medications that we can give for that. Some feel very nauseous. They are not able to. They don't feel like eating any food. Anytime they even smell food, they feel very, very sick. So these are some of the side effects that most chemo patients would have.
Okay. That's not too bad.
Well,
because after you stop the chemo, the hair comes back.
Yeah, mostly if you stop the chemo, it comes back.
The dry skin goes away.
The
darkness of your skin goes away.
It comes back. Everything.
So it comes back. Your eyebrows will come back.
But some of them don't know that it will come back. I mean,
it will come back.
What's that?
Communication.
Okay.
Yeah.
Okay. And what about radiation?
So radiation, It's mainly, sometimes they can develop some ulcerations where it has, like ulcer means wounds, where the radiation has been thrown to. There are rare situations that the radiation may lead to a different form of cancer.
Okay.
But it's very rare when it comes to radiation therapy. Yeah.
So those are the side effects, generally?
Yes, generally.
Okay. Some of them, at least, most of them are manageable.
Yeah.
Especially the chemo ones. But you know, after the chemo,
the vomiting is not easy. Some of them really vomit so much, they feel very weak.
But this too shall pass.
It shall pass.
The vomiting will end at some point.
It will end.
Okay. All right. So that's to do with the side effects.
Side effects, yeah.
What are some of the myths that exist in our communities about breast cancer and its treatments?
This question. So myths. I mean, people think that breast cancer, I mean, can go on its own, or it can be cured with some herbal medications.
Okay.
I mean, from my experience, I haven't seen that. I don't know if there is an existing, I mean, herbal treatment that can cure that. I'm very open to learn more about it, but so far I haven't seen any. Yeah. The other methods, when they see as I said earlier on, every breast lump is a breast cancer. No, it's not. Some are benign lesions, which
I took one out of somebody a few.
Very
I don't like that fine needle aspiration thing. Lump, excision. Nothing is wrong. Happy. Go home. We glue the wound very nicely, so the sky is looking nice.
You glue. Wow, you are a high-tech doctor.
We don't stitch the. We glue the wound.
Wow.
Look nice. No pain. No. She had a bath on it the same day. It was really cool.
Nice.
But then the results came. It's a normal this thing. And we're very happy.
Yeah. So those are the major myths I come across.
Lady Ajo, what myths are you familiar with breast cancer and its treatments?
Well, most people also believe that spiritual prayers can take it away. So you can pray the cancer away.
Okay. We believe in prayers, but we have to do something to it.
Yes. You need to teach people that prayer has what it will do, but there's a responsibility to taking care of the illness as well.
Okay. What else?
Now that also goes into the denial that we still talk about. Everybody will give you advice as to how you should live. That's why sometimes it's not best to break the news to other people because
that person now becomes a source of potentially negative information.
Exactly. Yes, because then you are sitting at home.
I'll tell you some filler before you finish.
You are sitting at home trying to think about how to go about it. Then they are bringing this today, malam, tomorrow this. Yeah. Somebody has a cure, whether you like or not. It's a problem shared, it's a problem solved. So everybody's trying to give you a solution to it, and that could lead you to a more difficult point where you can't even make a decision because the options that will not work are more than the ones that will work.
Okay.
And I want to add also, people think that the treatment is one size fits all. Everyone has his own treatment regimen. So if maybe your relative or someone has had it and was treated in a particular way, someone will say, someone had, my auntie had it, we didn't do mastectomy, but you came and you needed it, so I don't need to do it. No, everyone has his own way that we need to manage
deal with it.
So when you have to break the bad news, do you tell them that they should go and bring a relative or you give it to them?
Oh no! So usually I ask the person, do you want someone? Do you need someone to be around
before I tell you what I'm going to tell you?
Yeah. Hey. Now I have the results of whatever test. Do you want me to tell you alone, or you need someone to be around? Someone will say, "Oh, I want maybe my family, my husband, my wife, or my father, my sister to be around."
So you do reschedule the day?
Oh, I mean, anytime that's convenient. I should wait for them to come or another time.
Like 3 days time, that means they'll be thinking about what to do for 3 days time.
So
I think that's a torture.
No, it's not torture.
They're choosing the torture, but
the minute you tell somebody that, do you need me to call somebody? Already you sent a signal to the brain that it's
a bad news.
It's bad news. So the person right then and then, the anxiety has already set in, so they're not even thinking straight. So that's why we say that, okay, give the news, you, the doctor, go with the counselor. Let the counselor assess the person, start to talk that, oh, you know, you've not been feeling well lately due to this, we've come to talk to you about it. So, do you know anything about breast cancer? And the doctor has said this, that. But have you seen patients that have survived after being diagnosed with breast cancer? Oh, no, I have not seen. Oh, look at 1, look at 2. The brain begins to process things differently. Before you even drop that one, no, you've given the person a lifeline.
Doctors didn't know this.
Oh no, but sometimes, right? Some of the patients might not really like understand fully your explanation. Might want maybe someone in their family who is a little bit more educated than them to be around. So you give them that option. If they say no, oh, tell me now. I'm very free. I'll just tell you, right?
So the story I wanted to tell you was a lady came diagnosed with breast cancer. She was with her mother, and so treatment was offered to her. She declined because she wanted to give birth. So the focus was just to give birth. She has to give birth. Newly married, she gets pregnant. During the pregnancy, the cancer gets worse. Some treatment was given to her. She delivered. The thing became large, fungating, smelly. Eventually, they had to do the mastectomy. By then, it had spread, and then she died. Apparently, the reason why she wasn't coming for treatment was because of the mother. Was the mother was the one who was insisting that she shouldn't use this treatment that had been offered to her. And that brings to the point you were making. That the news that we are breaking to the other person over there, that person mom may be our biggest enemy.
Sometimes the patient handle it better than the third person sitting there.
Ideally, the patient should be the one to receive the news. So. Ideally.
That is a very...
And one other thing, let me add. I mean, there have been advances in managing patients with breast cancer in pregnancy in such a way that you don't really have to terminate the pregnancy.
Yes, I've actually managed one before.
Yeah, so, I mean, if someone is pregnant, you are diagnosed with breast cancer, it's not the end of the world. Yeah. You don't have to think of having to choose between your baby and yourself. So
I remember we had a patient like that who we discovered the lump when she was pregnant, and the surgeons examined, and then we had to schedule her procedures. Yeah. It was mastectomy, cesarean section, chemo, everything in different in a sequence. Yeah. So they had to do the mastectomy first before we delivered the baby. And by the time we delivered the baby, the wounds had healed enough for her to start her other treatment. So it is possible, even though you are pregnant, to arrange the
I think the education should be broadened in the way we communicate about breast cancer. Everything you hear about breast cancer is limited. Like you're saying, we should show more lifelines to the people when we are communicating about breast cancer. Let's let them know that you can live life after that. It doesn't end there, because we are making them out to be, people, when you speak to people about breast cancer and the fact that the treatment is there, they tell you that, the way society stigma, the way society will treat you after you having breast cancer, it's as if you are, it's equal to HIV.
How would they know?
Well, you have, what differentiates a woman from a man? When you see me.
No, how would they know?
How would they know that you have done, you've had
a mastectomy?
Oh. So now that the doctor is talking about reconstructive surgeries, okay, like you said, if they can afford it.
No, even if you can't afford it, there are prostheses you can put in your bra. Even foam you can put in your bra. But you don't do kabawe.
It's not as easy as you are saying it.
Putting the prosthesis in the bra.
Let me explain this to you. This is part of your body.
No, I'm not talking about their psychology. We are talking about stigma.
Stigma, for them, they don't, it's not about even you noticing, but it's about them knowing that this is not me. This is something else.
So the stigma is in their head.
Because of
they are stigmatizing themselves.
Because of that image, they project. Even if you see them and you tell them, "Oh, you look nice," or you comment about anything negative, they think it's because of that thing that you're saying. That meanwhile, you have not probably noticed. Papa.
It's not easy.
Okay, so so if she's lost her breast and she can't afford reconstructive surgery, how can you get them in a good mental frame of mind, a good state, for them to be able to continue living?
Well, I mean, for me, one of the first steps I'll take them through is something I call grief counseling. Like I said to you, whatever changes what is reality to you and introduces a new normal to you puts you in a state of grief. And grief is in stages. The first stage of grief is denial. And then you begin to reflect and begin to accept it, and then you begin to adapt to a new way of living. So first of all, once you are able to get the person to accept their new reality, then it is time for you to do a mindset transformation in a way that they begin to view themselves differently and more beautiful mentally than just what is physically in front of them. Then they can begin to accept themselves, build confidence to live with their new reality and not feel like they are losing out on anything.
And after that?
And after that, they adapt to their life daily.
Their new normal.
Their new normal. It's not you see, no form of healing is an event. It's a process.
Okay.
It takes time. There are days that you would even with a normal human being, there are days that you feel down. There are days that you feel bad. Let the person know that it is also part of the process. That days that you might look at yourself and you go down and say, you cry it out. However you feel, every emotion is valid. Let it pass through you, but don't stay there. After you're done with that, accept it and go forward. Because you see, life has a way of rebuilding itself when you give it a chance and you are willing to live it. So once you do that, you will find interest and new love for more things. Don't get attached to the things of your body, but rather the value that you produce.
Asamo. Dr. Saki.
Yes.
How can we improve screening?
Okay, so.
But that is what I want people to leave today with. Deciding that from today I am going to. And then any suggestions you have for the medical professions as well as to what we should be able to do.
So I think major stakeholders in the communities, whether opinion leaders, church leaders, hospital leaders, whoever, should create an environment where, women and men equally are educated about the risk of getting breast cancers and encouraged to either examine themselves as regularly as possible. There should also be avenues in various hospitals to set up screening, opportunities for patients who want to walk in any time of the month. It doesn't have to be only in October. If possible, every time, anytime, a patient will be able, like the way they have ENT clinic for the pregnant women and the children, there should be more like breast clinics where patients can come in and get themselves examined if they have any.
Should we examine all pregnant women?
So yes, it's very important because
at what month?
So usually there's no right from the onset.
At what month? Give us a month.
A month. Oh, right. The moment you find out that you're pregnant, you should be examining yourself.
So first trimester. We should examine them.
Yes, second trimester.
As part of their booking requirements.
As part of their booking requirements, yes, because they are still at risk of. In fact, the pregnancy hormones would actually increase the risk of. If there are cancer cells, it will cause the cancer cells to increase more. So these are the things we have to look out for. We shouldn't. I've had some patients who had the lump during their pregnancy. They went for ENT and were told, it's because you are pregnant. Maybe it's just the hormonal changes, it will go. But eventually it ended up to be breast cancer. So we should have the lowest, threshold as much as possible for any breast lumps in women or in men. Yeah. then early investigation for such lumps, and encourage all our youth and people within females, men, everyone should try to examine themselves as often as possible.
Lady Ajo?
Yes, boss.
Any final words?
To you, the doctors, and to the public.
To all of us. You can send the missiles to
everyone
individually.
Well, to the doctors, I would say that expand your care. It's not just about your technical terms.
Yeah.
These are real human beings that have to accept a new reality. Go beyond that and throw them a lifeline. Give them more hope in how you communicate the illness and how you break it to them. Now, for everybody listening to us, breast cancer is not the scare. Ignorance is the scare. The fact that you don't know means that you cannot do anything about it. Get tested. Know what your conditions are. If you need treatment, please take it. Life doesn't end over there. You can go ahead and live an amazing life, even with the diagnosis. Thank you.
Life does not end with the breast cancer diagnosis.
Yeah.
There's life after breast cancer.
Yes.
Ladies and gentlemen, we've had a very enlightening program. I'm grateful to our guests, Dr. Dorcas Osei, who is a general surgeon, and Lady Ajo, who is a counselor.
Yes.
And has been throwing missiles.
Yes, a lot of missiles on my side.
Oh, it wasn't intentional.
But we are very, very grateful. Everything has been valid and very... Mr. Kante will tell you that he didn't know half the things you've talked about today. And so, even our young man is not on this side.
He was checking his breast.
So from now on, we'll all be examining ourselves. And those who are married will be saying, hey, madam, let me examination. We'll all become doctors in our house. But the thing is this. It's better to find it for us to tell you that it's nothing than for you to assume it is nothing and we discover that it is something.
Yeah.
Next week, we shall come your way again with a brilliant show, lovely guests, and an interesting topic. Our exit song is by Dinah Hamilton, and it's Pentecostal Praise. Have a lovely week. Bye-bye.
ZED 101.9 FM.